The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody, and welcome. My name is Cindy Andrick, and I am the Manager of Family Support here at the Children's Cardiomyopathy Foundation. Today, we're hosting the Updates in Living with Heart Failure for Pediatric Cardiomyopathy Community webinar, and we're really glad that you can join us. We have some housekeeping notes that we want to go through before we begin. If at any point during the presentation you need technical assistance, you can type your concerns into the chat window, which is in the control panel. If you have any audio issues, you should be able to switch between your computer speakers and your phone if necessary. And to provide the highest quality sound during the webinar presentation, all attendees will be in the listen-only mode. However, we do encourage your questions throughout the presentation, and we welcome them. So you can submit any of your questions in the control panel, which the question box, which is in the control panel. And we'll reserve the last 10 to 15 minutes of the presentation to answer those concerns or questions. If the control panel is preventing you from seeing the screen, you can always minimize it by clicking the orange button, which is at the top of the control panel. If you want to then redisplay it, then just click on the arrow again and it will show up. We also will be recording this webinar presentation, and it will be available on our website as well as our CCF YouTube channel. So we're really thrilled to have Dr. Rakesh Singh with us today. He is wonderful, and he's got a great presentation for us. Hi, Dr. Singh. I just want to give you a little introduction here. Dr. Rakesh Singh is the Medical Director of the Heart Failure and Transplantation Program at Hassenfeld Children's Hospital at NYU Langone, and he is Associate Professor of Pediatrics at NYU Grossman School of Medicine. He received his undergraduate degree at Cornell University before attending medical school at Duke University School of Medicine. He trained in internal medicine pediatrics at Yale University and at pediatric cardiology at Columbia University. Dr. Singh specializes in caring for the child with heart failure due to cardiomyopathy, congenital and acquired heart disease, as well as caring for children after heart transplantation. He also has specialized interest in clinical research and has co-authored over 60 peer-reviewed abstracts and publications in the field of pediatric heart failure and transplantation. So I am thrilled to have Dr. Singh here with us today. At this point, I am going to turn over the presentation to Dr. Singh, and he is going to take over the slides from here. Perfect.
All right, well, thank you for that very kind introduction, and good afternoon, everyone. Thanks for this very kind invitation to speak with you on this snowy afternoon here on the East Coast. So I was asked to talk about living with heart failure, updates in nutrition, exercise, restrictions, and medications. I just wanted to change the title a little bit, if you don't mind, to Thriving with Heart Failure, because I think that's where we are nowadays in our field. We've gotten to the point where we can help our children thrive with this diagnosis. So it allows them to grow, to develop well, to prosper, and to flourish. So I'm going to talk about some ways that I think we've been able to help families like yourselves cope, but more importantly, flourish with this diagnosis. So I want to give a plug to this excellent resource from the Children's Cardiomyopathy Foundation. This was a book put together by many people in my field, cardiologists, nurse practitioners, and others. It's an excellent resource. In fact, I print it out from their website and I have it bound and I give it to all my families when I first meet them with a new diagnosis, either in my clinic or in the hospital. So please go to their website, look at it if you're interested, but I'm going to be referring to this booklet a lot as we talk about the various topics that I mentioned before. So chapter 4 in the book talks exactly about exercise, restrictions, and nutrition. So briefly, what are the benefits of exercise? I mean, we all know that exercise is good for children, but I don't think we truly understand how it can be very beneficial for our patients with cardiomyopathy. So we know that exercise increases muscle mass. It also increases mitochondria, which are the small cells that exist inside every cell that provides energy. So increasing mitochondria gives more energy to the things that we use every day, such as our arms and our legs, and also other types of muscles in our body. It also reduces acid production in the blood called lactic acidosis. So the less lactate we have in the blood, it actually decreases the stress on our hearts. So theoretically can improve our heart function. Exercise also improves blood flow to contracting muscle. And so obviously with more exercise, the increased flow allows for better exercise capacity. I think the most important thing for our patients and for our children is that it can reverse some of the adverse effects to the heart muscle. So it promotes what we call ventricular remodeling. And so there are very interesting studies that have shown that heart function can improve with exercise. It decreases the heart rate, it decreases the blood pressure, it reduces your catecholamines, which is things like epinephrine and adrenaline in your body, which we know is not good in our patients with cardiomyopathy. And most importantly, it improves their functional status. Functional status is the word we use about everyday life. So being able to keep up with their peers, go to school, all the things that I know we all think about every day. So exercise is very good for everyone, but especially in our patients with cardiomyopathies. What are the different types of exercise training that we think of? Well, there are two types, pretty logical. There's aerobic exercise, the things that we all do, hopefully on a regular basis. So walking, running, yoga, going to the gym. So all those types of aerobic exercise improve your functional status. Again, allow you to be more active and to be less fatigued. Again, it also has been shown to reverse the effects of the heart, that damage that may have already occurred. So promotes reverse remodeling. The other type is strength training. And this is a different type of training where you're trying to improve muscle mass. But in the process, you also increase your bone mass. And when a lot of our patients are on medications that can put them at increased risk for things like osteoporosis and bone fractures. So exercise decreases the risk of fractures in our patients. It also reverses and prevents deconditioning. So a lot of our patients, when they're initially diagnosed, before they're treated appropriately with medications, get deconditioned. And so strength training can help prevent that sort of atrophy and wearing down of muscles. And interestingly, it also improves your respiratory muscle strength. So things like your diaphragm, which helps you breathe. So strength training can help improve weaknesses of respiratory muscle, which is especially important for our youngest children who are quite sick in the hospital. Well, how about children who have advanced heart failure from cardiomyopathy and are awaiting transplant? There have been multiple really nice studies that show poor functional status before transplant is associated with worse outcomes after transplant. So again, it's an independent risk factor of how you do after transplant. So again, very important that we focus on trying to improve functional status in patients we know are going down the pathway of heart transplantation. And so your exercise goals would be to create a training program that decreases frailty, which basically means weakness of the muscles, improve the respiratory muscle strength of the lungs, create greater reserve in your skeletal muscles, like your arms and your legs. And we know by doing this before transplant, we can have shorter time you're on the ventilator, the quicker you're up and out of bed after transplant, the shorter amount of time you stay in the ICU, and the floor beds. So again, focusing on exercise, even in our sickest patients with heart failure, has been proven to improve outcomes after transplantation. So if you look at the studies and all the expert recommendations regarding exercise in patients with heart failure, it's very clear in the adult world that large clinical trials have shown that the training is safe, it reduces deaths and hospitalization, but more importantly, it improves how they feel and their quality of life. So it's very standard in the adult world, if you have heart failure, that you need a regimen of exercise to help you, along with all the other things that we think of with heart failure treatment, like medications and so forth. So if you look at all the guidelines from all the major societies, both here in the US and across the world, it is recommended that you exercise if you have heart failure. And it's actually what we call a class 1 indication. That's the highest level of indication you can have. And it's based on really good exercise research that shows it's safe and it's helpful. How about with our children? Well, it's also recommended. It's a class 1 indication, but unfortunately, we don't have the high quality data at this point. We have what we call expert consensus. And I think the main reason why we haven't produced high quality data is that there are still some concerns about safety. And I think unlike the adult world, we have a very mixed population, a heterogeneous population of diagnoses. And so I think that we don't have enough data to support these recommendations from a research perspective. And I think there are a lot of great studies that are ongoing, and I suspect we'll have more data that's going to show that exercise is safe and recommended for all of our patients with cardiomyopathy and advanced heart failure. This is an interesting study that was put together by the Action Network. I'm sure many of you are familiar with the Action Network. And this looked at all pediatric heart failure centers across North America, and they were asked, what do you do in terms of exercise training in your patients who have heart failure? And of all the centers, 24 centers responded, and less than a quarter, or so 17%, routinely provided exercise training to kids with heart failure. So a small percentage did it on a routine basis as part of their prescription of care to families. That number went up a little bit to about a third, or 32% of centers, providing exercise training to kids on ventricular assist device, or VADs. So again, not the majority. And when you ask the centers that were not doing it on a regular basis, the most common reason was they did not have the adequate knowledge of how to actually implement a safe exercise training program at their hospital. So they were interested, but didn't have the resources to put it together. And so the centers that have been doing it more often have started to publish their data on how effective it is. So one large group is the group of University of Pennsylvania and the Children's Hospital of Pennsylvania, or CHOP, that have shown that for many decades, they have a pediatric cardiac exercise physiologist who provides individualized exercise training recommendations. And so what they will do is they'll do a baseline CPET test, which we'll talk about in a second. After that test, they get baseline numbers on that patient, and they provide an individual training prescription, which the family can hopefully do at home or maybe an outpatient rehab center at least 2 to 3 times a week. And then they bring them back in to do a repeat CPET to see how they're doing. So CPET stands for cardiopulmonary exercise test, and it measures heart rhythm, blood pressure, oxygen saturation, and breathing all at the same time while exercising. It can be done in many different ways. It can be done as something as simple as just walking, or a 6-minute walk test. We can do it on a treadmill and have you run as far as you can go, or we have you sit on a stationary bike. And what's really nice about these CPET tests is it provides objective measurements of data of how your heart, lungs, muscles, and your metabolic response is to exercise. Metabolic response has to do with looking at anaerobic and aerobic exercise, the production of lactate or acid in your blood. And so it really gives the exercise physiologist a nice idea of what you can do and what's safe to do, and then can give recommendations based upon those results. One of the things you may hear about is that we can actually estimate functional status, meaning how much you can do. And one of those common indicators is what we call peak VO2. And that just looks at oxygen consumption at peak exercise. And those numbers are important. So they go up to as high as 100%, all the way down to 0%. And it's based upon your age and other factors. And so we know that people who have less than 50% peak VO2 can sometimes be an indication for heart transplantation, especially in our patients with dilated cardiomyopathy. So not only can this CPET testing give us valuable information that can provide an individualized exercise program, but it can also provide information as to severity of heart failure and whether we should be thinking about evaluating for transplantation. And this just shows sort of what an example of a CPET may look like if you're using a stationary bike. So you can see here that you can have a pulse oximeter. You have a mask that you breathe into that provides very valuable information about your lung function, your lung volume, and also sort of respiratory gas analysis to see how well you're breathing out carbon dioxide and breathing in oxygen. You have EKG leads, so we can monitor heart rhythm, heart rate, blood pressure cuffs, and obviously we can change the resistance to provide increased work product. And so again, really lots of valuable information that's recorded and interpreted by the exercise physiologist that can help individualize the plan of care for our patients. Well, how about specific diagnoses? So is exercise safe if you have dilated cardiomyopathy? And so there's been a lot of great research that cardiac rehabilitation, so again, an individualized, supervised rehab program, is safe in both children and in adults with dilated cardiomyopathy. One study showed that children with dilated cardiomyopathy who participated in this type of rehab had improved aerobic capacity, meaning they were able to do more, feel better, based upon a 6-minute walk test, and also had decreased waist circumference, so also had improvement in their metabolic profile in terms of their weight. And if you look at patients with more advanced heart failure, so the group from CHOP have shown that patients who participate in cardiac rehab, if they have a ventricular assist device, not only is it safe, but if they have a regimen where they increase the speed on the pump, meaning that as they sort of recover postoperatively from their VAD, you increase the speed, meaning you give them more blood flow to the body, it shows that that allows them to do more as they wait for their transplant. So again, you can manipulate these devices to improve the quality of life as you wait for transplant. How about our children with hypertrophic cardiomyopathy? So traditionally, I would say that the general consensus by experts, including myself, is that we have cautioned against participating in vigorous athletics because of this risk of significant heart arrhythmias, especially the ventricular types, that can lead to sudden cardiac death or sudden cardiac events. There have been more larger studies recently that have shown about 2/3 of these sudden cardiac events in patients with hypertrophic cardiomyopathy occur during routine activities, meaning non-vigorous athletics, so sleeping or resting. In addition, they've noticed that athletes who have hypertrophic cardiomyopathy, who have a defibrillator or ICD, have had similar events from their ICD, regardless of whether they've participated or refrained from sports. So again, these are not rigorously tested endpoints, but it does seem to suggest that vigorous activity may not always be the inciting factor for sudden cardiac events in many of our patients with HCM. And actually, more recently, there have been some very nice adult studies in patients with hypertrophic cardiomyopathy who had monitored supervised exercise regimens in the range of moderate inactivity, so not vigorous. And they have shown that there have been some improvement in the wall thickness on echocardiogram and their ability to function with no increase in adverse events. And in fact, there's right now a pretty large study that's looking at high intensity exercise. So again, the things we've not been recommending in adults with hypertrophic cardiomyopathy. So I'm hoping that in the next few years, we'll have a lot more information about how safe it is for our patients with hypertrophic cardiomyopathy to exercise, what type of exercises are safe, and what else we can do to increase and improve their quality of life with this diagnosis. Competitive sports, this is a common question for our families with a child with cardiomyopathy. So we define a competitive sport as an organized team activity with frequent training and intense levels of exercise. As such, taking breaks and self-limiting activity is generally discouraged at this level of activity. And we know that the stress on the heart with intense exercise, even if it's brief in time frame, can be dangerous. And so some of these activities we've talked about include things like soccer, sprinting, swimming, football, basketball, hockey, again, on the competitive level. And so generally speaking, children with cardiomyopathy are not allowed or not recommended to play competitive sports because of the possibility of a sudden collapse or risk of increased heart failure. But the most important thing is to discuss the specific sport with your cardiologist, exactly what the sport is, what the expectations are from the coach, what your child wants to do, so that everyone's on the same page. And so, I don't have an absolute yes/no when it comes to competitive sports. I always look at the patient individually, look at their echocardiogram, look at their other testing, look at what the child wants to do, and hopefully can come to some sort of common ground. Now, it's not always possible because obviously we want to keep everyone safe. But again, have an open dialogue with your cardiologist so that expectations are very clear. And most importantly, if we are unable to clear for sports, alternate activities should be discussed. And so I don't like to just say yes or no. I like to say, well, what is it about that sport that you like? And so I can maybe help you and the family figure out if there's anything else we can do. Because we do know it's a significant loss for the child and for the family, both in terms of the well-being, but also in terms of the bonding they have with their teammates. And so again, the most important thing is to talk with your cardiologist about what's important to you and your family. So in summary, exercise and physical activity are important for everyone, including for those with cardiomyopathies. For infants and young children, I always say regular child play is okay. One, because you're never going to be able to restrict a young child anyway, but two, it is safe because they will self-limit if they feel tired. In older children, I always say regular exercise, usually doing PE in school. Recreational sports are possible and usually encouraged because we know exercise can improve your heart failure symptoms and make children feel better. But again, just check with your cardiologist before starting any exercise program. And really, you want to ask very specific questions about which exercises are safe, how often can you do the exercise, how long can they participate during that period of activity, and how intense, and if any modifications or restrictions should be put into place. And again, if your child has not been very active or has been mainly sedentary, especially with the pandemic, I recommended slow increases in exercise intensity. And again, your cardiologist can help you with that. So just switching gears, we'll talk about good nutrition. So before we talk about things specific for patients with cardiomyopathies and heart failure, always important to just go back to your basics. So this is a nice little poster from choosemyplate.gov that I think just reminds us what we should aim for our children's plates. So again, half should be fruits and vegetables, and there's nice tips at the bottom there in terms of fruits can be smoothies, frozen fruits, whole fruit is better than juice. About a quarter of your plate should be grains. So, whole grain pasta, cereal, breads. Proteins, you can think beyond things like chicken and hot dog and burgers. You can think about nuts and beans, other types of poultry and seeds, seafood, eggs. Those are all good protein choices. And in dairy, you can't forget that we all need to give calcium. And you always want to think about skim or 1% milk in our older children, and yogurt qualifies too. So we know that nutrition and heart failure is something we focus a lot of time on when I speak with families and when I meet with our patients. We know a lot of our patients who have advanced heart failure have very poor nutrition. And it's multifactorial as to why nutrition is poor in these patients. The more common reasons, which I think everyone understands, is there's usually decreased intake. So there's a lot of fatigue. So in our younger infants, it's shortness of breath. They just get tired feeding. Lots of belly aches. If you talk to most adolescents who have significant heart failure, the belly aches are the worst part, the nausea. It's an appetite suppressant. And so again, the intake is just not where it used to be. But there's also a lot of increased needs that the patients need. So they lose a lot in the GI tract because there's lots of swelling of the GI tract, so they don't absorb as well as they should. Heart failure is an inflammatory type disease. If we test a lot of the inflammation markers in the blood, they're elevated with heart failure. So inflammation does not allow you to absorb food very well. We know that when you have heart failure, your heart beats faster to make up for the decreased squeeze of the heart. And so it's like running a marathon. And so they have increased metabolism. So all these things lead to not enough energy to meet the increased demands of the body. And it's also important because we know from studies that if you have poor nutrition, you don't do well waiting for your heart, and you don't do as well afterwards. So again, poor nutrition is an independent risk factor for not doing well with your transplant. So that's why we spend a lot of time coming up with a good feeding regimen for our patients when they have heart failure diagnoses. There's even more data to show that nutrition is important. So the Pediatric Cardiomyopathy Registry, or the PCMR, has shown that up to 1/4 of children with dilated cardiomyopathy meet the criteria for being malnourished. About 18% of children who are waiting on the heart transplant list have BMIs less than 5%, which put them in the range of severe malnutrition. And we know that even if we are able to improve their weight, so if we control their heart failure symptoms with medications or with a ventricular assist device, we find that their growth commonly doesn't catch up. So what I tell families is the weight we can usually put back, but their growth velocity will take a couple of years to come back. So again, focusing on nutrition really has a big impact on how they do down the road. Feeding tubes. So I know this is a common area of questions and appropriate concerns about our youngest children with heart failure. So again, why are feeding tubes needed in some children? Well, it's again, they have reduced intake, poor appetite, again, related to decreased stamina, shortness of breath. Sometimes their liver is quite distended, which pushes up against the stomach, which causes them not to be hungry. A lot of our patients have really bad reflux and other things associated there. But it can also be, the feeding tubes can be used in children who have a history of vocal cord dysfunction from maybe a prolonged intubation. They have poor coordination for swallowing, and they may have developed oral aversion. And so these are all things that require our patients sometimes to need feeding tubes. And we know that sometimes even with a feeding tube that goes into the stomach, which is a nasogastric tube or NG tube, sometimes children can't tolerate that. And so sometimes the tube has to be advanced further into what we call the jejunum, which is part of the intestine, so it goes past the stomach. Or in some cases, we work with our dietitian and nutritionist to work on formulas that are more basic, so not as complex, so that we call hydrolyzed or elemental formula. So while there's a lot of advantages of NG tube feeds, we do know there are risks associated with that. And so we know that for patients that are at home, inadvertent removal occurs frequently, and it's a very common source of frustration for families and parents. And so coming up with a plan before a patient goes home is very important to us, so we know what to do when the tube comes out. And so, you know, again, that's something we can try to plan for and try to mitigate as much as we can. And we know that repeated insertion of the tube is uncomfortable for children. So it's stressful, and it can lead to food refusal or oral aversion down the road. So it's not without risks. For our patients who are sicker, we have lots of families who get IV or TPN nutrition. And so it's very useful, but again, is not without complications. And so it's something that we use cautiously and carefully in our hospitalized patients, and sometimes as an outpatient. And so the key here is that we have a large team, a multidisciplinary team of health professionals like a dietitian, a speech language pathologist, an occupational therapist, along with their cardiology team that create an individualized feeding therapy plan to support you and your children, and to make sure that we provide you with everything you need to be successful. Another common question we get is sort of nutrient supplementation. What is safe to give to our children? What is the right amount to give to our children? So focusing on the basic things, so protein, that's a very important thing that our dietitians focus on, because we need to make sure that with heart failure, you have enough protein to help with wound healing, support this inflammatory response of heart failure, and preserve your skeletal mass so that you don't become emaciated and you have wearing down of your muscle. Fatty acids, so for our patients, especially our children that are hospitalized, who have prolonged periods of TPN, where they're not getting much by mouth, we have to supplement fatty acids. And so you will commonly see MCT oil or things of that nature being given at the bedside, in addition to the TPN that's given continuously. We also have to sometimes supplement with fish oil, because we know that these essential long-chain fatty acids are important in our young children's development of visual gains, their growth, their brain function, and their immune function. And these omega-3 fats also reduce inflammation and sort of decrease our platelets, which are the part of the blood cells that create clots. And so we want to prevent that type of activity in our patients who are on VADs because we don't want blood clots forming. So again, fatty acid replacements are important in these types of patients. Vitamin D and calcium, I would say that over half of my patients are on vitamin D and calcium supplementation. Again, because they're at risk for developing bone disease and fractures. And so the American Academy of Pediatrics commonly recommend that we supplement our infants with 400 IUs and children over 1 year with 600 IUs. And our dietitians are very good at monitoring our vitamin D levels and helping us determine whether we should be supplementing. Same thing also with calcium. Magnesium, I would say at least 30% of my patients are on oral magnesium. This has to do with the fact that we use a lot of medications that cause you to lose magnesium in your urine. So your diuretics are one common medication. And so we commonly will measure magnesium at all of our visits and supplement as we need to. Some other elements like zinc and selenium are antioxidants. And so we know that having adequate amounts of those elements can sometimes improve cardiac function. And so we also make sure that we have enough supplementation if needed, especially for our patients on TPN. Liquid intake. So we know that too much liquid can lead to swelling or edema, and that fluid then can go into the lungs and cause shortness of breath. It can also cause stomach aches, again, because of the swelling of the intestines, or can lead to other heart failure symptoms. So it's very common for especially our patients who have advanced heart failure, where we'll restrict them to maybe 1 liter to 2 liters a day of fluid. Salt or sodium, we commonly will restrict for patients with severe heart failure because salt basically goes with fluids. So if you have increased salt in your diet, it causes your body to resorb or take in more fluid, which can lead to swelling. So salt restriction is something also we focus on, and we have our dietitians work with families to understand exactly, how much salt is safe. And for some of our patients, especially our teenagers, we have to restrict caffeine. And that's a hard thing for some of our teenagers because they've grown up with caffeine intake as part of their daily regimen. And so for our patients, especially with hypertrophic cardiomyopathy, we have to educate about caffeine. And so, I was actually surprised when I looked up how much caffeine is in each beverage item. And so, coffee obviously has quite a fair amount of caffeine. But things we may not think about. So iced teas and sodas, Red Bulls, again, common drinks that our teenagers drink need to be monitored because they can lead to palpitations and in rare cases, heart arrhythmias. So in summary, good nutrition is a very important part of managing heart failure. That's why, here at NYU, we have a dietitian at every outpatient clinic visit who's available to help families come up with the best nutrition plans for their kids. So the types of food and beverages can help or can worsen symptoms of heart failure. And so we know that our youngest children usually require increased calorie formulas or supplemental formula in addition to eating solid food. Occasionally, we do require feeding tubes, NG or G tubes, if they can't take enough by mouth. You have to also remember that too much caloric intake and obesity can also have detrimental effects. So it's important to maintain good calorie goals and good weight tracking as part of your care. And we always recommend a team approach between the cardiologist, the nutritionist, and your pediatrician. All right, so switching to our last topic that I was asked to speak about is medications. This is chapter 6 in the CCF booklet that's online. So I'm just going to run through some common medications that your children may be on and answer any questions that you may have about them. So the most common medication that our children are on are what's called ACE inhibitors. These meds lower blood pressure by relaxing the blood vessels, and this allows the heart to not have to work so hard to pump blood to the body. We also know they can improve heart function over time by reverse remodeling, and thought that by blocking stress hormones that are constantly attacking the heart, it allows the heart to recover and hopefully get stronger. So ACE inhibitors, I would say, are the most common medications we use for our patients with cardiomyopathy. And again, these are coming from the CCF book, but these are the common ACE inhibitors that we put children on. So starting on the left side there, captopril is the medication we tend to use in infants because it lasts the shortest amount of time, so you can titrate it carefully. And so this is given up to 3 times a day. And again, it works by lowering the blood pressure and allows the heart to not have to work so hard. Some of the common side effects include a dry cough, maybe a little bit of a headache and being a little bit tired. When you first start these medication or the doses are increased, lightheadedness is not uncommon. So just make sure that if you feel lightheaded, to sit down, and if it becomes significant, to let your cardiology team know. Enalapril is the medication that we use for our younger children. That's twice a day. And then to the right side there, you see lisinopril, which I tend to use in my school age to teenage children. They all work the same way. The big thing about lisinopril is it's once a day. So it's really easy to give and easy to remember to give. I always recommend families and for our children who take their medications themselves to leave it in a place they're always going to remember. So whether it's next to their phone or next to their toothbrush, that way they always remember to take it when they're doing those things every day. Next category of medication, very similar to ACE inhibitors. They're called angiotensin receptor blockers, or ARBs. And ARBs also help the blood vessels relax and are an alternative to those who can't tolerate ACE inhibitors. So probably the most common reason in pediatrics we use ARBs is if you're intolerant, you've got a persistent dry cough. The 2 most common ARBs are losartan or Cozar, and valsartan and Diovan. Again, similar side effects as ACE inhibitors. These are given once daily like lisinopril. And again, are good alternatives if you can't tolerate ACE inhibitors. All right, so this is a new medication alert. This is Entresto, also known as valsartan plus sacubitril. They have all the commercials on TV of people being very happy, in case you happen to catch these commercials. So sacubitril valsartan combines a first-in-kind neprilysin inhibitor. That's sacubitril. And what neprilysin is that it helps, it inhibits an enzyme that breaks down proteins that allow you to pee off extra fluid. So by inhibiting this enzyme, it allows more of this protein to exist in your body, hopefully then letting you pee off extra fluid. So it combines sacubitril with an ARB, which we already know about, is valsartan. And so this was studied in adults in very large trials, and it was the first medication in about 2 decades that actually kept adults with heart failure out of the hospital and actually had them survive longer. So because of that, the drug company put together a pediatric multi-center randomized trial called Panorama, which they're currently finishing up this year, that is looking at patients who have heart failure and either giving them this drug, Entresto, or enalapril. And the preliminary data was promising to the FDA, where they actually went ahead and approved it for children down to the age of 1 year. So this is a medication that cardiologists can use. I tend to use it in patients who either have more severe heart failure or are not tolerating their enalapril or lisinopril. That way I can just go to an ARB plus this new medication. It has similar side effects to ACE inhibitors. And from my perspective, the couple of times I've used it, it's actually quite well tolerated. The most important thing is that if you're switching from an ACE inhibitor to this new medication, your cardiologist will have to have you stop the ACE inhibitor and have about 2 days without a medication before starting the Entresto to decrease the risk of an allergic reaction. Next category of medications you may be familiar with are what's called beta blockers. They block specific beta receptors on blood vessels and heart muscle. This leads to the heart to beat more slowly and with less force. They also bring down the blood pressure. And it's thought they can improve heart function by, again, blocking these bad effects of stress hormones on the heart. So they promote reverse remodeling. These are the 2 common beta blockers that we use in kids, carvedilol or Coreg, and then metoprolol, or also known as low pressor or Toprol XL. Carvedilol is usually given twice a day. It can cause some side effects, especially when you start initially or you titrate up the medication. Dizziness, drowsiness, sometimes nausea, And so these are things you want to look out for, and let your cardiologist know if your child is experiencing these. They usually go away after first few weeks. It can also lead to teenagers some depression, trouble concentrating, changes in mood. So you want to be look out if you see those symptoms, let your cardiologist know. All right, another new med alert, Ivermectin. So this is a medication that kind of works like a beta blocker, but not technically a beta blocker. It also slows the heart rate. There was a recent trial looking at this medication to basically a sugar pill or a placebo in children with dilated cardiomyopathy. It was a small trial, but it did show that it safely lowered the heart rate in children with heart failure, and it did improve the squeeze of the heart, or the ejection fraction. It was about twice as good in the patients who received Ivermectin versus those that received the sugar pill. And so the thought is by decreasing the heart rate, it may allow for improvement in heart function. This is given twice a day. Again, the side effects can be a lower heart rate than you want. And so when you first start this medication, you can have a little bit of lightheadedness. And so this is a medication that your cardiologist will prescribe if they feel that maybe the beta blockers aren't a good choice, or maybe you're a better candidate for this medication. But again, early on, we don't have a lot of data, but yet it is something that we can use for our patients with heart failure. Digoxin, this used to be more commonly used, I would say, about 10 or 20 years ago. We have newer medications that I think are safer, so I think it's less commonly used, mainly because there's a narrow window of safety for this medication. And so if you have too much of the medication, you can have a slow heart rate and have other toxicity. And so it's important that if your child is on this medication, you give it exactly the dose prescribed. And if you notice any unusual side effects, drowsiness, dizziness, weakness, those are reasons to call your cardiologist. Diuretics, I would say, are probably the second most common medication after ACE inhibitors. These are water pills, and they're used to help the body get rid of excess salt and water by increasing urination. This increases the amounts of fluid in the blood vessels, gets rid of extra fluid building up in the lungs, and may decrease any swelling you may notice, especially in the morning around the eyelids or maybe in the ankles. And there are 3 different types of diuretics that you may hear about. They all act on different parts of the kidney. So one works on the loop part, one's called a thiazide, and one's called the potassium sparing. So these are the common diuretics we use in children. If you look on the left side of the screen, those are loop diuretics. So furosemide or Lasix is by far the most common, but we may also use bumetanide or Bumex. Again, the complications essentially is that they can, because you're urinating a lot, you do have a lower blood pressure, so you might get dizzy. You might have some signs of low electrolytes, such as cramping. And so it's very important that if your child has an illness, like a fever, runny nose, cough, diarrhea, to speak with your cardiologist about maybe holding back the diuretics, because you don't want to exacerbate dehydration. On the top right, you see the common thiazide diuretic that we use, which is chlorothiazide or Diaril. On the lower right, you see the 2 potassium-sparing diuretics that we commonly use, spironolactone or eplerenone, also known as aldactone or Inspira. Again, the advantage of those is that they, as the name says, they spare potassium. And that's one of the common things, is that with lots of diuretics, you tend to lose potassium, but these can actually keep the potassium in the blood. It's also thought to help with the remodeling of the heart. So we commonly will use this for our patients if we see lots of scarring, especially on the cardiac images of the heart. Another common medication your children may be on are blood thinners or anticoagulation. This decreases the risk of clots that can form inside the left ventricle, the main pumping chamber, especially if it's boggy and dilated and not squeezing well. We don't want any clots to form there and go to places like the coronary arteries and cause a heart attack, or go to the brain and cause a stroke. Just need to know with these medications, you may see a lot of bruising. That's okay, that's not dangerous, but obviously if you see significant bruising that's painful or bleeding out of the ordinary, those are things to speak to your cardiology team about. And obviously special precautions should be taken to prevent bleeding and injury. These are the common anticoagulation that we use. So aspirin is very commonly used. It can upset the stomach. And also want to look for any irritation of the stomach or any blood in the stools. So if you don't need any bloody or black stools, those are reasons to let your cardiology team know. On the right side are the what we call the more powerful blood thinners, things like warfarin or Coumadin, or the injection enoxaparin or Lovenox. We tend to use these more in patients who have more significant dysfunction or have other reasons to need a more powerful blood thinner. These obviously, while they work very well, have their own problems. Warfarin, Coumadin takes a few days to start working. You commonly will get a blood test called an INR. You have to be careful not to eat too much food that has vitamin K in it, so lots of the leafy green vegetables. You need to speak with your cardiologist if the diet changes. And obviously, you're more increased risk of bleeding, so avoid contact sports and things of that nature. The big disadvantage, as we all know, of enoxaparin or Lovenox is it's an injection. So my last slide is just some helpful tips that I put together. Hopefully, you'll find useful regarding medications in our kids. Just know that frequent changes are common, so don't be surprised if your cardiology team is changing medications around. When we start medications, we tend to start low to minimize side effects, so we will titrate them up. Sometimes we'll ask you to do it at home, or sometimes we'll have you come in frequently to clinic so we can check things like blood pressure or blood work. We also commonly increase medications, especially in young children, because obviously as they grow, we have to increase the medication so they're getting the same amount per their body weight. And sometimes if there are side effects, we may come down on the dose. So frequent changes are common, nothing to be worried about. Unfortunately, we do need to do a fair amount of blood work. So with ACE inhibitors and diuretics, we have to follow electrolytes very closely. If you're on digoxin, again, because there's a risk for toxicity, we have to check levels. So blood work is important. So ask your cardiology team at every visit if blood work is needed. Find a good compounding pharmacy, and I would talk to your team because I'm sure they have a good relationship with a compounding pharmacy. That basically means that for our younger children who require liquid medications, your local CVS or Walgreens may not do that. And so finding a good compounding pharmacy that has overnight delivery service can make your life a lot easier. Take your meds every day at the same time in the same way, either with food or without food, and that includes weekends. So for teenagers, sometimes it does require them having to put an alarm on, take their medications and roll back over and go back to sleep till noon. But again, these medications work best if you give it at the same time every day. And if you miss a dose, give it right away or wait for the next dose if it's almost time for the next one. Never stop or change doses without checking, again, because some of these medications have side effects, which you may not be aware of. And the most important thing is always call your team if you're unsure what to do. That's what we're here for. We're available 24 hours a day. So, whether it's missing a dose, we're all human. We forget to take medications, spitting up doses, spilling your medications, leaving them at home when you go on vacation, when you're allowed to take a vacation eventually. We don't want you to worry. So call us so we can talk to you about anything to worry about. And thanks again for the invitation.
Thank you, Dr. Singh. That was excellent. Really appreciate your time today. I just want to remind people that are listening, if you have any questions, you can always type them into the question box. I do have a few questions that were submitted to me before the webinar, so I just want to go through them. One of them is, do you need a physician referral for cardiac rehab if you want your child to participate in cardiac rehab?
Yeah, that's a great question. So usually you do, and I think that's because the rehab team would like to know what the diagnosis is, if there are any restrictions from the cardiologist perspective as to what's safe and what's not safe, and for how long they would like the rehab team to work with your child. So I would always ask the team to put in the referral, to get the prescription, so that that can move the process forward better. Okay.
Thank you. This has been trending a little bit on our Facebook page. What are your thoughts about a supplement such as elderberry to boost immune system?
Yeah, I can't say I know a lot about elderberry. I think that the most important thing for a lot of these supplements is to make sure that there's no interactions with the medications you're already on. I haven't seen any data regarding the antioxidant value of elderberry. But again, there are so many out there. The most important thing is just researching to make sure there's no interactions. And again, being very upfront with your team that you're considering, these types of medications.
Okay. Somebody submitted a question. Their son was recently diagnosed at 13 with HOCM, and we're told there is no tool at this age to input his information to determine his risks, but that there may be one published soon. Do you know anything about that? It feels like they are winging it right now, what he can and cannot do.
So just to confirm, the diagnosis was HCM?
HOCM, yes.
Oh, HCM, yeah. So, it is true that the criteria that we tend to use for risk stratification, meaning what are your risk factors for having an adverse cardiac event, are based upon adult criteria. But I can tell you that there has been active research looking to see if we can come up with criteria in teenagers that are either the same as adults or different. And so for what I do for my patients is that I look at the whole picture. So I look at all the testing that's being done. I always do common things like Holter monitors. I always do a stress test to see if I can see what their blood pressure does at peak exercise, see what their heart rate does, make sure there's no arrhythmias. Looking at the family history to see if there's been other patients with hypertrophic cardiomyopathy. If there was, how significant was it? Did they have any cardiac events? And so, you know, with that information, I'm usually able to give a sense to the family of what they can and cannot do. But I think the specific question from this family was, you know, do we have specific criteria for teenagers? We don't. But I think with the current data we have, I think we can give pretty good information to most families.
Okay, great. Thank you. Last question I have is, are there any promising therapies other than medication that you mentioned that are on the horizon to treat heart failure in pediatric patients?
Yeah, that's a great question. I mean, I think there's a lot of great research looking. So a lot of the medications we have don't get to the root cause of the problem. They don't actually, for the most part, reverse the damage that's been done to the heart. So there's been a lot of research looking at the use of stem cells in patients with heart failure and a lot of the adult heart failure world. There's been some studies that suggest it may work, but again, not at a point where I think it's going to be common practice. There's also a lot of medications looking for example, in patients with hypertrophic cardiomyopathy. There's what we call the signaling cascade that leads to the very abnormal myocardium under the microscope, meaning that the cells of the heart look very abnormal. So looking to see if you can interrupt that pathway to see if you can reverse the problem with hypertrophic cardiomyopathy. And so there are some clinical trials looking at medications used for other reasons, like in cancer treatments and things like that, to see if they can reverse that abnormal heart muscle. So I think in the next, I'm hopeful that the next decade we'll have medications that not only just treat symptoms, but hopefully also reverse the damage that's done to the heart. The last thing I want to say is that a lot of great research that I think is pretty close to prime time in terms of genetic therapy and genetic replacement therapy, especially in patients who have cardiomyopathy and also neuromuscular diseases such as Duchenne muscular dystrophy, where you actually replace the protein that's missing, the dystrophin gene that's missing, to actually improve heart failure and improve their skeletal muscle function. So I think there's a lot of great things on the horizon, but unfortunately nothing that I'm aware of that is ready for everyday clinical practice.
Okay, great. Well, thank you. I think that's all the questions that we have that were submitted. And I really appreciate you taking the time today on this snowy February to speak with us. This was really informative. I just want to remind all of the people that are in attendance that if you want to refer to the Heart Failure Guidebook, that Dr. Singh was referring to, it is available on the Children's Cardiomyopathy website, which is www.childrenscardiomyopathy.org. Also, February is Heart Month, so you can go to the website and look for any information that you might want to share with people to shed the light on pediatric cardiomyopathy. Last, this webinar will be available once it's downloaded and put on our website, probably within a week. So you can go to our website if you want to listen to it again or you want to share it. We also have a YouTube channel, which is called CCF Heart Kids, and it will be available there within a week. So I want to thank you, Dr. Singh, so much. This was really great, and it's great working with you, and I really appreciate your time today.
My pleasure.
Thanks. Have a great day, everybody. Bye-bye.